Okay, guys, as you can see, I'm using a little bit different formatting today. Hope this people like it a little bit better. If not, we'll continue trying to adjust. Um, but I have been listening to your complaints and trying to make it a little bit more enjoyable and educational for you. With that being said, we're going to talk about care of the patient with urinary problems. We're in chapter 66 in our book, and we'll be talking about urinary problems for the next little bit. So, our objectives is to collaborate with the interprofessional team to coordinate care and promote elimination in patients with problems with their urinary tract. We're also going to be talking about education to help patients to prevent infections, both at home and nosocomial infections, because urinary tract infections can be very detrimental, especially to our elderly population. We also want to be able to teach our families and our patients about not only urinary tract infections, but also about urinary incontinence and ways that that can be treated today. So, first, we're going to talk about incontinence. And incontinence is the involuntary loss of urine, and this can be both a social and hygienic problem. The main thing I want you to take away from this is that it is not a normal consequence of aging or childbirth. So, again, just because a patient has had vaginal births or is of an advanced age does not mean that they should be incontinent. Again, it is not a normal consequence of aging. And a lot of our patients just assume that because they have had vaginal births or because they're of a certain age, that this is just a rite of passage, that's something they have to deal with. And that's not necessarily true. So we do want to keep that in mind, that patients not only have the stigma that of the incontinence, but they also just think there's nothing you can do about it because it's just where they are in their life cycle. When we look at the different types of incontinence, we're going to look at stress incontinence. This is the most common type. This is when patients, usually females, will lose their urine when coughing, sneezing, jogging, or lifting something heavy. And where that comes from is when the urethra is not tight enough to overcome the increased bladder pressure, causing a contraction in that muscle. This is common after childbirth, but usually it strengthens back up. But during menopause, during low estrogen levels, it can also, because of the decrease in elasticity, can also lead to stress incontinence. But it is not a normal rite of passage with aging. There is reasons for it. And so there are things that can be done to help with stress incontinence. Urgency incontinence is the loss of urine for no apparent reason after sudden feeling of the need to void. But a lot of times it happens very quickly. And these, a lot of times, can be treated with medication, such as anticholinergics. Look at that chart on 66 4. They'll also talk about avoiding caffeine and alcohol. There also is a lot of different behavioral interventions that we'll talk about briefly here in a few moments that can help a lot with these patients as well. So make sure that you are doing a thorough H&P on these patients, and that you are familiar with looking at the urinalysis that we talked about briefly in the last chapter. We're going to continue now with our discussion on incontinence. A lot of times these patients who are having urinary incontinence are very embarrassed. They don't really want to talk about it. So it's important to make sure that we listen to what they have to say and that we are familiar with the different types of incontinences so that we know how to care for these patients appropriately. The most common type of urinary incontinence is stress incontinence. This is usually the main feature is the inability to retain urine when laughing, coughing, sneezing. So this is the most common type. Patients with stress incontinence cannot tighten the urethra enough to overcome an increased bladder pressure. And this is common after childbirth, but a lot of times because that pelvic floor has been weakened, but a lot of times with pelvic floor exercises, these patients can regain a lot of that um, problems with stress incontinence. Again, after menopause, because of the low estrogen levels, women again can have problems with stress incontinence. Again, because with low estrogen levels, you have both vaginal urethra and pelvic floor muscles become thinner and weaker without the estrogen, and this leads to more problems with stress incontinence. And these patients, a lot of times, are just very embarrassed by it. They don't really want to talk about it. But especially if you're working in an area such as for the female patient in the gynecological arena, you want to make sure that they are aware that there are treatments available to them. Urgency incontinence is loss of urine for no apparent reason. It's normally when the bladder is full, and it's for the contraction of the smooth muscles. Urgency incontinence is also known as overactive bladder. And we've all seen the commercials for different medications that can be used for overactive bladder. A lot of times, this urgency incontinence can be caused from because the patient's taking different diuretics and they just don't have the ability to hold their urine on the way to the bathroom. This category, the urgency incontinence, is you see this a lot of times in older females. Overflow incontinence is the type of incontinence occurs when the bladder has reached maximum capacity and some of the urine is leaking out. It's kind of this is the overflow incontinence is when you'll see this again with older females where they kind of have a constant dribble because they're unable to keep that urethra completely closed. A lot of times this is with patients who do not completely empty their bladders as well. Lastly, is functional incontinence. Now, this is incontinence that you see in patients who have cognitive impairment. A lot of times, this is with your patients who have dementia. To maintain continence, an adult must be aware of the need to urinate, and patients, of course, with cognitive impairment do not have that, and that's the functional incontinence. So those are the types of incontinence that it's important for us to know and be familiar with. So what are the causes of incontinence? Etiology. There are a lot of different causes of incontinence. Just keep in mind that some are temporary and others are permanent. When patients have had surgical procedures in that lower pelvic structures, whether it be radical prostate surgery or gynecological surgery, because of cancers, this can also result in the patients having incontinence. We'll talk about prostate cancer later, but a lot of these men have a lot of trouble with and have to do some retraining after prostate surgery. So that's things to keep in mind. When we talk about incidence and prevalence of it, keep in mind that 45% of women over the age of 65 have some level of urinary incontinence. The risk for incontinence increases with different chronic conditions, whether it be diabetes or having a stroke, of course, cognitive impairment, and it also just mobility. If you have a little bit of an overactive bladder and you have difficulty getting up, you can have a lot of issues with incontinence because your sensation of needing to void doesn't get to you quick enough. Also, with a lot of your neurological disorders, such as multiple sclerosis and Parkinson's, these patients can have a lot of mobility issues leading to incontinence as well. When we look at factors contributing to incontinence, it's important that we look at chart 66-1. It looks at different medications that can lead to incontinence issues, whether it's diuretics, and sometimes it can just be the need to change the time of day they take their diuretic. A lot of times these people, especially if they're elderly, may take their diuretic with breakfast, but they don't get up that early, so breakfast isn't until 10, and by then they go to bed at 6 or 7 because they're going to watch TV, whatever. So sometimes they just need to start taking their diuretics earlier. It also can be some anticholinergic medications. Can have side effects of trouble with both cognition and the ability to void is important. Also with some CNS and some depressants such as some opioid analgesics can also limit the person's ability to realize that they need to void. We've already talked about some disease processes that can make the patient void. But one thing that I want to bring to your attention, again, I'm back on chart 66-1, is when you're talking about your patients with depression, a lot of times, especially when you have middle-aged or older, or actually elderly or older women, they'll have some stress incontinence. And then it's like, well, I'm already wearing this pad because sometimes I can't make it to the bathroom, so I might as well just use it. And a lot of time it's because they now have decreased self-esteem and self-worth, causing their incontinence to actually be worse. So it's important to look at those psychosocial things when you're looking at patients with depression, especially in your older population. They also talk about inadequate resources, making sure that they have what they need to manage their urinary incontinence. It may be that they don't have people to help them go to the bathroom, or that they don't have correct eyeglasses or canes. So you just have to keep in mind when dealing with our patients, or perhaps they do have it at home. Maybe at home they have, when they got to the hospital, they were brought up on a stretcher. Their cane got left in the car, or it got left at home because they were on an ambulance. And now we're trying to get them up to the bathroom, and they're like, yeah, I need this, this, and this. And by the time we get all that together, they've already gone to the bathroom. They've already voided on themselves, and then they're embarrassed. So it's important to keep in mind what we need to do and what resources we need to have available to care for these patients. We've also already talked about the care of the patient with urinary incontinence, but also look at that chart 66-2. It can be very helpful to us in looking at what kinds of problems these patients are having. I do like how it shows here in our assessment and noticing section. It talks about in the history, it gives us some questions about urinary incontinence. A lot of times you'll see these in gynecological offices that they'll ask you to answer sometimes never, or sometimes. And if you answer sometimes or always to some of these questions, it would behoove the healthcare provider to do a more focused urinary incontinence assessment. I know they talked a lot about of the female incontinence issues in maternity, so I'm not going to go through a lot of that now. I am going to take one more moment to look at chart 66-5, looking at best practice for patients, talking about bladder training and habit training to reduce urinary incontinence. A lot of times people just don't realize that some simple things such as trying to void every so many hours will assist in their incontinence care. There's different things that patients can do other than medications. There are pelvic floor exercises, as well as just timing and training and staying away from caffeine, that kind of stuff. The last thing I want you to look at is on the chart 66-6. It's the patient and family education, talking about urinary incontinence and how to help the patients deal with urinary incontinence. It's a good little read to give us some ideas with that. We'll come back with bladder infections in a little bit.